Finished with measles yesterday. Measles, highly contagious. Rubella is like his little cousin. It's not as bad as regular measles is. Remember the other name for measles. Measles is rubeola. Okay? A lot of these national certification exams, I can put rubella right next to rubeola, and it kind of sort of makes you kind of guess which one is which. Right? So remember that distinction. Rubella, aka German measles, also highly contagious, but the symptoms are a lot milder than they are for rubella. Okay. When here it tells you it's milder, you'll have a diffuse punctate maculopapular rash. Rash is very similar, but instead of it being blotchy red, it's a lot lighter, more of a pinker color. Okay. Usually you're contagious 7 days before, up to 7 days after the rash appears. It kind of sort of resembles some of the other rashes for scarlet and cocci and mono. So the rash is a way to denote the difference between measles and rubella. Right? One is red, bright, blotchy. The other one's not as blotchy. It's a lot lighter. The other way to denote the difference is fever. For measles, you have a very high fever that can go up to 104, 105. With rubella, it's low grade, usually between 99 and 101 or so. So it's more of a low grade fever. This is supposed to be similar with the rash. And some more rash. Another rash, very similar to measles. But usually children are very mild. Usually children don't really have too much of an issue with this. Okay. People that do have more of an issue are us adults, because we end up having more of an immune reaction because our immune systems are a little bit stronger than some of these kids. Usually incubation period is about 14 to 21 days. The prodrome itself, right, because this has 1 to 5 days prodrome, low-grade fever, mild coryza, headache. Remember, prodrome for measles is high fever, conjunctivitis, coryza, and cough. There's no cough here. Okay, so another way to denote a difference for prodromal stuff. This is supposed to be mild conjunctivitis. Not necessarily a great picture, but okay. Another way to denote a difference between measles and rubella is that lymphadenopathy. You don't usually see lymphadenopathy with measles, but you'll have some lymphadenopathy with rubella. Here it tells you some places: postauricular, occipital, cervical. The most common place for the adenopathy is postauricular for rubella. Okay, that is the most common. If you want to highlight something else, you can highlight the Fauchnier spots. Measles had Koplik spots. You remember those Koplik spots were those little white spots that you saw on the buccal mucosa for measles. For rubella, you have Fauchnier spots. The Fauchnier spots, there's small red spots that you'll see. Sometimes you can say that they look like petechiae on the soft palate. Sometimes they can cross over to the hard palate as well. So if they're on the soft palate, it's still okay. So another way to denote a difference. Just remember, Koplik spots for the measles are actually pathognomonic. So if you see them on the buccal mucosa, then it's probably the measles. Here, it's not the case. So Fauchnier spots are not pathognomonic. So just because you see them doesn't mean that, hey, it's rubella. Just keep that in mind. It's not a definitive for rubella as it is for the measles. This stuff usually happens maybe in 20% of cases. And here's some occipital and postcervical lymphadenopathy in a child. Okay. This is what we would consider Fauchnier spots. They have them both on the hard palate and soft palate. Versus Koplik spots, which are on the buccal mucosa, so not necessarily get them confused. Erythralgia, less common. Arthritis. Females, more common in males, at least arthralgia. Some of the thought process behind that is usually they have a much stronger immune response, which is why they're a lot healthier than we are, right? Which is kind of nice. They have some hormonal influence, like estrogen, which actually boosts some of that immune response, also increasing antibodies. So that is a possible reason for why it affects women in their joints more than it does affect males. All right, we're going to talk a little bit more about some of the lab stuff here in a little bit, but you can see some leukopenia, some organ thrombocytopenia, not a lot. So it's not one of those big things you need to concern yourself about, but it is important to know as we move forward that if your patient is pregnant or has been exposed to rubella, it becomes a concern. Right? When we talk about serious issues with rubella, it isn't necessarily us, the healthy folks. It isn't necessarily little kids that we said, hey, usually have mild symptoms and usually recover well. It's the pregnant women that usually have a problem with rubella. This is why they have a problem. They can end up with congenital rubella syndrome. Congenital rubella syndrome can cause spontaneous abortions, stillbirths, and congenital defects in the baby if they survive. Pregnant women usually don't get sick. Right? They may have some mild symptoms. The problem is that it's going to spread to the baby's intrauterine. And that usually leads to those possible birth defects, if not spontaneous abortions or stillbirths. One of the most important things that we need to do would be to assess the gestational age if this occurs. And the reason why we say that is because depending upon when it happens, which trimester is going to be the risk factor for that baby actually having congenital rubella syndrome. Here it tells you the first 16 weeks is our highest risk, right? So we'll look at first 0 to 11 weeks, you have a 90% chance of having the baby born with congenital rubella syndrome. 0 to 11 weeks. Usually the standard panel is when you show up for maternal care to your well-woman person or your OBGYN person, okay, one of the first things that they will check as a standard screen when you first show up would be for rubella. And we really want to get that checked before those 12 weeks because between 0 and 11 weeks, you have a 90% chance, highest risk of having that rubella syndrome. Now, 12 to 16 weeks, that risk drops 20 to 25%, and then after 20 weeks, it drops even more, where they say it's almost negligible that that baby will be born with congenital rubella syndrome if the mother acquires it after that time period. Right? So it's important for us to know if they do or they don't. Now you are going to have some issues, right? These are the issues that we just talked about. Right? Intrauterine death, spontaneous abortion, congenital malformations. Prevention is key. That's what we want. We want to try to prevent this. Okay? But if we do not, these are some of the possible complications that we're going to end up having. Right? And if you look at them, they like to attack some of the major organ systems. You have deafness, you have cataracts, microphthalmia, glaucoma. So it is affecting other issues. And that would also include your cardiac and your neurologic system as well. There's some other congenital issues that the babies may have. Okay, microcephaly, microencephalitis, mental retardation, hepatosplenomegaly. So these things can happen a lot. Sometimes it is seen at birth, and sometimes it is not recognized at birth, and it'll be a little bit before they actually recognize some of these things. So it might be a little bit later in the baby's time period that we'll figure out that they do have this. Some of the more severe cases, usually the baby will have blotches on their skin. And those are a lot more noticeable. if we haven't realized that the mom actually had congenital rubella syndrome. This is one of those possible babies. This is what we call diffuse punctate rash. Okay, here's another one. Here's another one. Okay, women usually have milder cases. And for the babies, sometimes, as we mentioned, it may be months to years before we recognize what some of those possible side effects occur. One of the bigger ones that we have noticed is that type 1 diabetes, usually that we get it at birth, usually we'll recognize it a little ways down the road for some of these babies. Okay, the diagnosis itself, usually what we do is clinical. It's usually a clinical diagnosis. I don't have to do a whole bunch of labs. I don't have to do a whole bunch of stuff. Dewey, it is important specifically for pregnant women to determine whether or not they are or are not going to possibly have congenital rubella syndrome with the neonate. So from that standpoint, we do have to do some sort of lab testing. We can do ELISA IgM, we can do period-acute convalescent, paired titers. We can do RC-PCR. We'll talk about that here in a little bit. But the importance for us healthy people when we get it, not a big deal. Usually we recover. Don't have to do labs. But if we're talking pregnancy, talking female, then yes, we should probably do some labs for confirmation. All right, here's some confirmation labs for you. We've got the IgM there for the ELISA. We've got the fourfold pair for the acute and convalescent phase serum. The other one that you can add on there is that RT-PCR. You can add that RT-PCR on. Remember, with some of these, you have that little window at the very beginning of any of those infections where that body, your body, their body, may not have developed that IgM yet. Right? So you have those first couple of days. And for healthier folks, usually you have mild presentations, which means they may not even realize that they have it at that point. Okay, so we have to be careful. So if you do have the option of doing RT-PCR, use that. That'll capture it no matter how early it is. Right? Because it's very specific. If you do think that you have some neurologic aspect, go ahead and do a CSF, a lumbar puncture. If you do find IgM in there, then you know it's penetrated the central nervous system. All right? One of the reasons why we do that. All right? It's really hard to tell whether a neonate has neurologic problems. Okay? So one way to tell would be doing a CSF, a nice lumbar puncture, to notice if they have any IgM in there. This thing happens everywhere in the world, more so to non-immunized personnel. Right? We talked about that herd immunity yesterday. So the more folks that are vaccinated, the better off we are. Right? Here it says prevalence in the winter and the spring. Primarily affects children, and we're generally the reservoirs for this disease process. How do we get it? Nasopharyngeal secretions, respiratory issues, right? Spread it, sing, yell, talk, cough, you spread it. It's extremely important when we talk about the little babies with CRS. They may shed this in their urine for weeks to months. That means if the people within that nursery are not doing the appropriate things, right? Wearing their little overall covers and their long sleeves and their little gowns and their masks when they're taking care of those little babies, they can spread it, right? As competent people, you guys, right? Healthy patients, not a problem. But we can spread it to other little babies. Those guys have not been vaccinated yet. So communicability, 1 week before onset of rash, at least 4 weeks after onset of rash is one of the reasons why it is so communicable. Susceptibility and resistance. Once you get it, usually you have permanent immunity, okay, to active infection. The biggest key to take away from this slide right here: do not immunize pregnant women. Do not immunize pregnant women. Right? MMR is a live vaccine. We do not give pregnant women live vaccines. If they do want to get pregnant, they should at least get the MMR at the minimum a month before they choose to get pregnant, so that it's working and doesn't interfere with anything else. Okay? A minimum of a month before they get pregnant, if they have not been had prior immunization with MMR. Any questions with that so far? No? All right. We'll keep those simple. You guys remember cytomegalovirus, CMV, your friend, HHV, right? So this is human herpes virus 5. That's its name, right? We're seeing it again. Remember, this thing can affect anything, any other symptom, any other system, eyes, brain, any other internal organ. There's your human herpes virus 5. Okay, so for healthy folks, we usually don't have any serious issues, right? We talk about neonates, right? They're lacking that immune system to fight stuff, and for the immunocompromised, right? Those are the guys that we're really concerned about with these things. CMV occurs in 5 to 10% of infants. Here it says blood transfusion seronegative infants. Right? There's some infants that are going to need blood transfusions. That is a way that some infants, neonates, get CMV. Another reason that they get CMV is that 50 to 90% of us, healthy folks, already have it latent in our system. If it does pop out for us healthy folks, usually we're asymptomatic, but we can spread it. Okay? Or we can spread it, which is how some of these things spread from people to people, even if we don't know that we have issues. Remember those HPI questions. Who are the people that are more at risk? The lower socioeconomic groups are at higher risk for CMV. So just keep some of those things in mind as we move forward. And in this case, when we talk about neonates and infants, lower socioeconomic have that higher rate of CMV. Here's a whole bunch of neurologic and liver issues, right? Because it does affect other parts of your body. In this case, we're not necessarily just talking about immunocompromised folks. In this case, we're also talking about neonates, right? So here's your lethargy, convulsion, icterus, TPI, corpora. So you're going to see some of those things with some of these neonates, right? Big thing to remember there is your intracerebral calcifications. Okay, that is something that we don't generally see, but we'll see calcium buildup in the brain of some of these babies, and they're just calcium deposits that are occurring. All right. Here are some of the other symptoms. Some of these little neonates that actually survive are gonna have complications. All right. What kind of complications are we talking about? Mental retardation, microcephaly, motor disabilities, hearing loss. Remember, these things like to affect the inner ear. They like to affect your central nervous system. Vision issues. If we talk about the HIV, CMV, we talk about choroidal retinitis, right? Eyes is one of the places where it likes to go. But remember, a pregnant person actually does get it. The likelihood of death in utero is there. It's a possibility. Other considerations, right? We always talk about the immunocompromised. Those guys, what is that, less than CD50? Yes, you guys remember that from HIV? Yeah. Less than CD50 for what? You guys remember what less than CD50 for CMV was? Corneal retinitis. That's what the guys with AIDS usually get, most common with CMV presentations. So here you've got retinitis, you've got your GI disorders and hepatitis. So babies can really be born with have some of these issues. Status post. Here's some corneal retinitis. So you've got a whole bunch of, if you guys remember, there's all your cotton wool spots over here. These little nickings here are what we call silvering. And you've got exudate coming out of some of these vessels. So a lot of bad stuff in that picture there. All right, diagnosis in newborns. Usually we can isolate it from urine. You've got a couple of other modalities there. Virus isolation, CMV antigen detection. If you do have PCR, all right, the last choice there is CMV DNA detection. That would be your PCR test. Most large facilities usually have PCR, so you can use PCR for this. That would probably be your best test out of any of the tests that we actually have for detecting CMV. This thing does occur worldwide. Most common folks is usually immunocompromised. For us, healthy folks, usually we don't have much of an issue with CMV. Usually we get over it really easy. Okay, there's some modes of transmission: CMV, excretion, urine, saliva, semen, cervical secretions. Right. We can have viremia, but we can be asymptomatic. Usually healthy folks. Humans were the only reservoir for this. Right? When you go home and you get your spouse or significant other, is a way that you can spread it. If your spouse does not have it and you do, you can give it to them or they give it to you, either way. Okay, and mucosal contact can also cause infection of the tissue, causing it to spread. Daycare is here, on here. Because the little kids are all going and hugging each other and slobbering all over toys and sharing the slobbered toys without them being cleaned. So you can spread in different ways. Most of the time, most of us are usually asymptomatic, in which case we do have a small possibility of spreading it. Usually for babies, they can excrete it for months. If we get it primary, if we're healthy and we never had it, and we get it, usually we can spread it as well for weeks to months after we get it the first time. If it reactivates, right, we already got it, if it reactivates, our likelihood of shedding is very low, and we're not extremely contagious at that point. But we still have the possibility of still spreading. If mom wants to breastfeed, status post delivery, and she does have this, okay, she can spread it weeks to months post delivery. So things to be careful with, things to educate your parent about, that they can actually spread this to babies. If the baby is born with CRS, okay, that baby can shed for the next 12 to 24 months. So that baby can spread it quite a bit. Okay, susceptibility, nearly universal, so it's worldwide. Proper hygiene and sanitation is key for this, especially if you're touching infected little neonates. We have some antivirals. We can use vancocyclovir, ganciclovir, or forcenet. Okay, so this is one of the ones that we do have something for. A lot of the other viral xanthoms that we are talking about usually do not have things to do. Usually they're self-limiting, and We don't have any antivirals or drugs that we can actually give folks. There's specific types of medications. Anybody have any questions? Yes, no, yes? EBV mono, aka kissing disease. Right? This is human herpes virus number 4. Viral syndrome, clinically fever, sore throat, often exudate. Right? So sometimes we may see this and possibly think that it's strep. Right? Cervical lymphadenopathy, but the differentiator here will be your splenomegaly. Right? The bigger differentiator will be your splenomegaly. And usually, over 90% of us already have this in our system. Here's some exudate in the posterior aspect of the throat. Like I said, this is one of those pictures that we had before. The exudate can be anterior or posterior to the anterior pillars that are right here. In this case, it's on top of the tonsils there. Fever is grade 97% of cases. All right. So the triad that usually presents with mono is usually fever, pharyngitis, and adenopathy. So the triad that usually presents with mono is fever, pharyngitis, and adenopathy. And those three usually you see, it's usually EBV. Okay. And your other symptoms that you could possibly have, chills, malaise, fatigue, myalgias. Right, so here's your sore throat. Now the big thing with this, self-limiting. You have to save care for your patient because splenomegaly is a thing with this. And once they get better, it's going to take them several weeks to months to actually feel better after the case has been resolved. Right? After they've gotten better, not a problem. Other things you need to be careful with is this thing may have high fevers. Right? Fevers may go all the way up to 104, 104.9. So be careful with the fevers with this. And then in younger children, you may have a little bit more milder symptoms. Now, jaundice is not a huge aspect with EBV. It may affect it, but not a lot. So it's not something to really hang your head on. Splenomegaly is maybe about 50% of these cases, not 100%. So again, splenomegaly isn't pathognomonic either. But the deal with splenomegaly is if we do find it, we need to protect them from high impact activities and contact sports. Right? The more common people that get this are usually teenagers. Right? And teenagers are doing a whole bunch of high impact activities. They're doing contact sports. So you need to protect them from themselves. If your spleen ruptures, that's emergency surgery. You need to lay it out that way. Okay? And until that spleen kind of goes back down, you can make sure that they're not doing crazy stuff. Okay? Now, there has been some association. Remember, this is a human herpes virus. Okay? And many of these have been associated with certain carcinomas. Carcinomas that have been possibly associated with this one are Burkitt's lymphoma and nasopharyngeal carcinomas. Okay? So keep that in mind. There are some possibilities of association with some carcinomas if you do have EBV. Okay, labs, we usually don't do. This is usually a clinical diagnosis. But if you want to, you can check for lymphocytes. Check for abnormal LFTs. It'll be your AST that's elevated over your ALT, right? Because this is not a sole liver problem. This is an other organ problem. So your AST will be higher than your ALT if you do liver functions check. But what we generally do is a mod spot test. We have that in the clinic. Get that done, you'll have your result back usually within 30 minutes for a monospot, and then you can see whether it's positive or not. So if you're working in a standard clinic, your best bet would be your monospot test. Here's your HHV4, human herpes virus 4 for EBV. This is a worldwide occurrence. 50% infected will be asymptomatic. Right? So if you're asymptomatic and you're kissing your significant other, you just spread it to your significant other. Okay? Some of these we have to understand that lots of healthy folks are asymptomatic. In this case, approximately 50% of them are. We are the only reservoir, usually it's person-to-person transmission, and usually oral secretions, oropharyngeal route is how we spread it. Okay, incubation is usually 4 to 6 weeks on average, with the ability to prolong. Okay, pharyngeal virus excretion may persist for long periods of time. But usually about 5% of patients usually acquire this and have it for longer periods of time. So it's a smaller. Susceptibility, infection, high degree of resistance. Even though we're not doing anything. Okay, we have no immunity to this stuff. And hygiene is the best thing to do. Treatment is basically supportive. We're going to watch them. We're going to keep them from getting hurt. Okay? Make sure you take care of the fever, because the fever is going to be high. And doing something innocuous. Remember, they're adolescents, so we don't want to necessarily give them aspirin if we don't have to. Alright? Because we have to control the pain from the pharyngitis and the fever. Tylenol usually works well. And we really got to prevent them from splenic issues. If they do have splenomegaly, you can always follow it with an ultrasound to make sure that you size it out to make sure it's going back down in the appropriate size. Adequate rest is probably one of the biggest things that we can tell these guys to do. And keep them from hurting themselves with splenomegaly. Anybody have any questions about that? No? Alright, mumps. This thing is contagious. It's a viral infection that causes painful enlargement of the salivary and parotid glands. Right, that's what it does. We don't see this very commonly in developed countries because we have vaccines here. But if you go to underdeveloped countries, this becomes a little bit more prone. Okay? So it's an acute viral disease. Okay? With fever, swelling, tenderness of one or more salivary glands, usually the parotid, sometimes sublingual or submaxillary. This thing can affect one side or both sides. Okay? Either or. Okay. Now the other aspect to the mumps is that it can affect specific other places. And the other specific places that we're talking about will be your testes, your brain, or your pancreas. Alright? This is what one-sided or unilateral mumps looks like. It's very telling. Okay? It's very telling. It's enlarged. On some folks, when they have bilateral, it looks like they have little chipmunks, like they've got little nuts in their mouth and swelling things out. Alright? So it's pretty noticeable. Here it tells you you're going to have a fever, unilateral or bilateral, either or. You're going to have dysphagia and malaise. So these guys may have some difficulty swallowing. Okay, if you give them something to drink, they may move down the side of their face. All right. You want to try to give them something soft to eat because they're going to have difficulty chewing. These are all things that you're going to have to tell your patient to do. All right. Now here it tells you orchitis is 20-30% of, remember, post-pubertal males. Same deal with euphoritis. Post-pubertal females but their numbers are a lot smaller. It's a lot easier to denote in males aortitis versus females euphoritis. In females, it may not be as prominent, and it may not present as mumps. It may present as lower abdominal pain or low back pain. Remember, some of the presentations will be a little bit different. Now, there have been some mump cases where they have not had the parotid swelling, okay, but they've only had the orchitis. Pancreatitis. Why pancreatitis? Well, the mumps like particularly granular type tissue, okay? Hence the salivary glands, right? Granular type tissue. Testes and ovaries, granular type tissue. This means that after an individual is infected with mumps, the pancreas can become involved as well. It's another one of those places where it kind of likes to go. Although this is a lot less common, right, than infecting the parotid glands, okay, the virus can directly infect the pancreatic cells. If it infects your pancreatic cells, they tend to become inflamed. Right? If they become inflamed, they can cause immune-mediated damage to the cells. And what specific cells do we have in there that help with insulin and glucagon and all that other stuff? Islets of Wagner, there you go. All right, one, right? So if those things get affected, these folks may end up with diabetes. So just things to keep in mind. It's a possibility because of the type of tissue that this thing has and the type of affinity that mumps likes for these particular tissues. It only happens in 4% of cases, but remember, it's still a possibility, right? It can also cause neurologic involvement. Here it talks about bronchitis as well. Okay, permanent nerve deafness, usually rare. A lot of these guys like the inner ear. And then there's some other possible symptoms here. You can end up with neuritis, nephritis, arthritis, thyroiditis, mastitis. This thing likes to go to a whole bunch of different places once it becomes systemic. So depending upon the area that it's affecting is a specific type of symptom that you may end up getting. Right. Now, in the first trimester for pregnancy, you can possibly have some spontaneous abortions. Thus far, there is no signs of congenital defect if a pregnant person ends up with the mumps, but there is a high possibility of spontaneous abortion during the first trimester. So usually as part of your screening, when you first show up to your OB/GYN or well-woman person, this is part of that screening. And here, if you want to really diagnose it, you can use your ELISA IgM. You can use RT-PCR for this as well. This is usually a clinical diagnosis. Usually we'll use the lab stuff. If we're thinking that there's an outbreak someplace, we'll use labs. Okay, we can use the ELISA IgM or we can do the RT-PCR. Okay, here's your occurrence. Rare compared to other childhood diseases, about a third are subacute. Okay. You guys remember what subacute means? It happens really slowly. Okay. Happens so slowly that your body may not even react to it. Happens so slowly that you may not even have any serious symptoms that go along with that. Okay. Until further on into the disease process. Right. Children less than 2 are subclinical. You remember what subclinical is that they present without obvious symptoms. You do a lab test on them, they're going to be positive, but they're basically asymptomatic. All right. Now, if that continues to progress on, they can become symptomatic, but again, it may take some time. Usually happens between the winter and spring. Usually in countries that have good immunization programs, this is usually not a problem. Okay? United States, usually not a problem. You guys, on the other hand, some of the things that we just talked about, which would be mumps, measles, rubella, I have never necessarily had to look at and treat. You guys, on the other hand, because the way medicine looks like it's moving forward with decreasing some of the vaccinations, you may see some of these things when you start practicing. So you guys may have a heads up on some of the folks like me who've been around for a while who really haven't seen some of these viral anthems anymore. But you guys are just getting out of school and understanding that this is a possibility. Okay. Modes of transmission, droplet spread, direct contact with saliva, we're the only reservoirs. And there you can see the little kid on the left there. Right, you can really see that. It's very noticeable. Him, I'm not quite sure, right? That may be a normal phase. Right. So when you're in a clinic and you think this is a possibility, and you are not quite sure, right? Ask them for a picture. Ask them for their driver's license. Okay, so that you can compare what they normally look like with how they're presenting. Right? With parents, it's huge. Right? Like, hey, do you have a picture of your kid? Most parents usually have tons of pictures of their kids on their phone. Right? And that'll allow you to look at what the kid looks like compared to what the patient looks like in front of you. All right? That's an easy way to denote if there are any serious differences there. Okay. Virus can be isolated in saliva 6 to 7 days before perioditis starts. 5 days after onset, CDC says to isolate. Almost all people with mumps recover without any issues or problems. Okay. But in rare cases, symptoms may worsen again after 2 weeks. But generally, they'll get better. Okay. We have no specific treatments for mumps. Okay. And then remember, we try to give parents those educational tips and hints. Hey, make sure they eat soft foods, make sure they eat soft diets, make sure they stay hydrated. Try not to give them foods that they have to chew a lot. Okay. Acetaminophen usually works pretty well. You can use Motrin as well if you like, for any of the fever, headaches, or discomfort. Immunity generally lifelong. Okay, so people were born before 1957. It is presumed that they have probably had measles, mumps, or rubella. Okay? That is a presumption that medicine makes. Because that was a time period before we had the vaccines. All right? So the assumption is that they probably had it, or they've been naturally immunized for it. Any questions about that? No? All right, let's go ahead and take a break before we start polio. So the next thing we're going to talk about is acute poliomyelitis. Okay, polio is a highly contagious, sometimes fatal enterovirus that affects nerves. Okay, it can cause permanent muscle damage. It can cause permanent muscle weakness, paralysis, and sometimes a couple of other issues static post the actual poliomyelitis. So they're telling you it's a viral infection recognized by acute onset of classic paralysis. Right? Many people who've been infected usually have no symptoms. Most others may have some mild symptoms, but usually people make it go away. Your body takes care of it and it goes away, no issues, no problems. But for the folks that do get it, what happens is that it spreads via the fecal oral route. Okay, it likes to replicate in the lymphoid tissue. You guys remember what the lymphoid tissue is? Like the tonsils and all the lymph nodes that are around your entire body. We said this was a fecal oral, so you're going to eat it. So it's going to go down to your small intestines, Remember, you had your prior patches in there. That's all lymphoid tissue, so it's going to get in there. Once it gets in there, it spreads and becomes systemic. Once it becomes systemic, this place likes the central nervous system, so it's going to go to the central nervous system. It can either cross the blood-brain barrier, or it can just enter the peripheral nervous system. Okay? Once it does that, it infects the anterior horns. You guys just did neuro. You guys remember what the anterior horns are? Horn cells? Yeah. There's motor nuclei in there, right? So these guys go in there. They like to destroy the motor nuclei in the anterior horns. And that motor nuclei is what controls the muscle movements in different parts of your body, right? So depending upon where in your central nervous system it affects, is usually what it's going to affect. Right? Most common is lower extremities. Okay? Can happen in your upper extremities as well. Unilateral, one side is usually most common. Can it happen on both sides?
Yes.
Yeah, it can happen on both sides. Okay? And that's really dependent on whether the virus has gotten to both sides of that nerve AO to affect both sides. Okay? Depends on quite a few different things, to include age and immunity status and all that other stuff. But yes, it can affect both sides. All right. Now, this thing causes flaccid paralysis. That means that you're not going to be able to use that one particular extremity because of the muscle weakness. Okay. So you end up losing the reflexes, right? Your muscles atrophy because you're not getting any movement out of them. And sometimes it may affect your diaphragm. So you may not be able to breathe. That is a bulbar type of poliomyelitis. That is the worst one that you can get. Have you guys heard of the iron lung?
Yes.
That a long time ago. But that is one of the things that we use for bulbar type poliomyelitis when they need help breathing. Okay. So it can cause a lot of things. Now, one of the things that I did not say it affected was the sensorimotor part, right? So this guy may have some flaccid muscle weakness, may lose all his muscle mass, right, due to atrophy. But if I were to do a sharp dull test on him, he would know. So you still have your sensory aspect intact when you have polio. Okay, so you're going to have a couple of different types of effects when you get polio, right? So if you look at this gentleman on the left, you see he has absolutely no muscle mass, right? Look, he doesn't even have a calf either, right? So this position is what we call hyperflexion. And usually it's weakness of the quadricep muscle causing a disproportionate pulling of that hamstring. Okay? Because that hamstring is what causes your leg to flex, right? So that's usually what's happening here. Muscles of the back of the thigh are a lot stronger than the hamstrings, than the quadriceps, so it pulls it back. That is one of the ways that you'll see that these guys present. Okay? If you look at the one on the other side, the little girl, you may end up getting leg length discrepancy. It's another possible presentation, and that's usually due to the uneven growth of the paralyzed leg. Okay? Especially because this happens a lot in kids. There may be a slight discrepancy there with that leg length. So these are ways that these guys can present. It occurs usually in your GI tract, as we mentioned. It's like those lymphoid tissues. When it goes down into your small intestines, it gets into those prior patches. Once it gets into those prior patches, it spreads to the rest of the body. Right? We did mention that it causes flaccid paralysis. The most common is usually unilateral. Aseptic meningitis in approximately 1% of cases. Okay? Aseptic meningitis is a complication of polio. Right? It just means inflammation of the membranes around the brain and the spinal cord, most commonly by the polio virus. The thing with the aseptic meningitis is that it usually doesn't cause paralysis. Okay? Unlike some of the other polios that they have, it usually doesn't cause paralysis. And then some of the common minor illness presentations are usually fever, malaise, headache, and lung. A lot of times this thing presents like the common flu initially, and then it goes from there. Right? In major cases, you're going to end up with severe muscle pain, neck, back stiffness, with or without flaccid paralysis. Usually that occurs a little bit later in time because the virus has to get in there and it has to start killing off some of those motor neurons. Okay. So paralysis of the polio, characteristically, it's usually asymmetric, usually one-sided, but it can happen on both sides. One-sided is most common. Okay, you'll have fever, and remember that you do not have sensorineural loss when you have that flaccid paralysis with polio. So those are all characteristic pieces that you should probably highlight. Right? So here's a way we characterize some of the different polios. So abortive poliomyelitis polio is just, it's a minor poliomyelitis. Usually affects younger children, and it usually does not, keyword, does not involve the central nervous system. So these guys usually don't have any issue with the paralysis aspect of polio. The non-paralytic polio is a more severe form of the disease, which usually affects 1% of folks, and usually that irritates more your central nervous system, and you end up with a lot of spasm versus paralysis. And then you have the paralytic poliomyelitis, which is the one that we're generally talking about, which is the one that we're talking about now. Okay, you have the spinal, which is the one that innervates the anterior horns and destroys all your motor neurons. Right? And then you have the bulbar. And the bulbar is the worst one. The bulbar is the one that actually affects the lower aspect of the brainstem. If you guys remember that, that's the area that controls your breathing, your swallowing, your speaking, your heart rate. Right? So if this is affected, then you're going to have breathing problems and cardio problems. Right? This is generally the most dangerous form of polio that we have, is that bulbar polio. Okay? So here's two more folks. So you guys remember foot drop from neuro? Right? That's weakness of your ankle dorsiflexors. That is a way that some of the polio folks present. Okay? A little foot drop. Right? No muscle strength there. But if you look at this gentleman on the left, right, and you see his foot, okay, that is what we call a club foot. Or if you want to be a smart person, you can call it a quinovarus foot. See that big C shape there? So the deformity is where that foot is drawn, turned inward and downward. Okay? And that often resembles a club, which is what they say, which is why they call it club foot. But that's basically just an imbalance of your calf muscles versus your foot muscles. Foot muscles are a lot stronger at that point, so it causes your foot to go into that shape. Right? That is a way that club foot appears and happens. You have other ones. You have varus. You have equivenous varus. That's where your foot turns inward towards the midline of your body. Okay, so it just turns inward. And then you have equinocavis, where your insole just arches up really, really high. Okay, and your foot kind of becomes a little C. So it is another way of presentation. That's all due to muscular strength. Muscles being stronger on one side than other. The ones that are stronger are going to win, creating that different shape. We've got this little girl on the right, which is where we have what we call hyperextension. Okay. And that refers to the knee joint extending beyond its normal straightened position. Normally we go to 180 degrees. She's way beyond that 180 degrees of extension, right? We call that back knee or genitus recurvatum. And that's just weakness of those quadriceps, keeping that hyperextension up. That's all that is. There's a mismatch between the quadriceps and the hamstrings, and in this case, it seems like the hamstrings are winning. All right? That's really what causes that. Usually, what do we do for treatment? Well, depends on the severity. But we can do orthotic bracing, we can do surgical intervention, we can do PT, we can do corrective spinal splints and casts. That's usually what they do overseas because they don't have much of this stuff, so they usually use a lot of corrective splinting if possible. Okay. Here's your extent of paralysis, spinal nerve destruction, right? So the extent of the paralysis is really going to be determined by the amount of motor neurons that are going to be destroyed by the virus. Okay. Depending upon where that neurologic system is affected, it can affect whether it's your muscles or whether it's your breathing. Okay. So it's really dependent. Okay. This little gentleman here has bilateral. Okay. So both of his legs are affected. A lot of children usually recover from this. They usually have mild symptoms and usually recover. But we don't know why some do and some don't. So the life-threatening paralysis will be your bulbar polio because it affects your respiratory and swallowing muscles. Some differentials that you can look at will be Guillain-Barré, but understand Guillain-Barré is symmetrical and starts at your feet and works its way up, right? Polio is not like that. Polio is, for the most part, unilateral. Right? Here's some other differentials. Paralytic polio. See neurosyphilis is in there. Usually, this is done by clinical diagnosis. If you really want to figure out what it is, you can use any of these. Stool, CSF, or oral pharyngeal secretions, but one of your best bets will be your stool. Okay, your stool sample is probably one of your best bets to determine whether or not you do or don't have polio. Right? Remember, it goes all the way down into your small intestines because it's fecal oral, so that stool sample will probably be your best. You can always do an ELISA IgM, looking for that fourfold, right, between the acute and convalescent. That is also an option for you. Prior to immunization. Okay. So, prior to immunization, you're susceptible after. You're not. The World Health Organization is doing a really good job by pushing out immunizations for polio around the world. Okay. That's usually the main strain right there, CBDP-B1. Sporadic occurrences, primary disease in infants and children. This vaccine was developed in 1952 to 1955-ish. This was the largest study in the world at that time, particularly with children. In 1954, they had the study done. The study incorporated 1.8 million kids. 1954, 1.8 million kids. And they went and they got the vaccine. Right? And the vaccine worked, and we've had it ever since. Since then, they've also developed an injectable vaccine, and we have an oral vaccine. So we've got a couple of different choices nowadays. Okay. Reservoirs, usually humans. spread it to each other, fecal oral route, pharyngeal spread, right? Fecal oral can infect your tonsils as well because of the type of tissue. And communicability there, it says not well defined. Okay, here's the two different types of vaccine. You have your oral and the other one would be your injectable polio. We don't have any treatment, we don't have any cure for polio. Once you got it, you got it. We have nothing to make it go away. What we can do is prevention. Prevention is key. Right? Whenever we talk about ID is prevention. If we can prevent it, let's prevent it. In this case, we have vaccines that actually work. Okay? Let's use them. The vaccine is effective in more than 95% of children. Because we have, for the most part, eradicated polio in the United States, we don't use the oral vaccine anymore in the United States. They use the oral vaccine everywhere else around the world. Okay? It's a cheaper version, and it works really well with an understanding that the oral polio vaccine is a live attenuated virus. So it's a weakened virus. There is a small chance that you can actually get it. Small chance. We here in the United States use the IPV, the inactivated version, and it is part of our childhood immunization profile that we have to give kids. Here's a whole bunch of places where the World Health Organization has tried to go and do or give polio vaccinations, and they've been killed. All right. A lot of places where this is still somewhat around are Pakistan and Afghanistan. Okay, polio is still around in those areas. Okay. Who here has not had chickenpox? Ooh, nice. All right. So remember, chickenpox, usually a childhood infection. Usually it can happen in adults. Okay. It's human herpes virus type 3. Okay. Human herpes virus type 3. Acute generalized virus disease. Okay. Onset low-grade fever, mild constitutional symptoms. Okay. Skin eruptions which evolve quickly. Right? How did we differentiate chickenpox from smallpox?
There's a hand and feet.
Okay. Location was one. Right? The cropping and what they look like is a big way to tell the difference. So it looks like another microscope. So there's your skin eruptions. Back of the papillary, face trunk, neck. Okay, vesicular 3 to 5 days. Right, they blister up, then they break open, then they scab up, and then you're all good, right? Just remember, all of these look different. You'll have little crops that pop up in different places, but if you compare them to other ones, they all look different. And they are not at the same time frame of growth. They're all in different stages. All right, here's a picture. Every once in a while, you may hear, this looks like a dewdrop. Right? You may hear a vesicle that looks like a dewdrop that may be associated with chickenpox. If you hear it, okay, may be associated with chickenpox. Here's another one. Right? If you look at these are all at different stages. You've got a big one here, you've got this little one that's just starting, you've got this one that's even smaller than that one. So they're all going to be at different stages as they continue to go along in their life cycle. Okay? These are commonly occurring crops, right? The ones that pop up are usually pretty similar, but then you get other ones that are not. So the stages are going to be extremely different as you look at them all. Cover a bunch of areas of the skin, more abundant areas of irritation, usually the diaper area and the axillary area. This is most communicable during the prodrome and early stages of eruption, usually in the first 48 hours before the skin actually starts getting those little lesions. Okay, here's another gentleman with some on his face. Here's another one with some on his back. Okay. Other locations of the lesions would be scalp, high in the axillary area. If it does come up in the membranes of the mouth, they tend to rupture really fast. And once you start looking at it, it makes it really hard to differentiate from herpetic oral lesions than it is from varicella because they're ruptured inside the mucous membranes already. So just keep that in mind if you're looking at it inside the mouth. Also happen inside the vaginal canal. Those cases, those rupture very easily as well. So they're going to look different than some of the ones that are out on the skin. Keep that in mind. It could be mild, usually atypical or subacute in some cases. Here's a little kid with it. Okay. So here, if there are constitutional symptoms, especially in adults, we have a much stronger immune response, so it's a little bit worse for us as adults than kids. Okay. Usually why it's worse for us. The fatality rate is pretty small, right? Not huge. Chickenpox or epidemics usually occur in the winter, early spring. And usually they happen in 3 to 4 year cycles. Right? So this is a mucal one inside the mouth. So they're already ruptured. So if you were to look at these, your likelihood of saying that that's a chicken pox is very minimal unless you have a history or unless you're seeing a patient in front of you with a whole bunch of pox all over his body. Right? So remember, these ulcerated lesions that may develop on the mucous membranes are ulcerated because the blisters have already ruptured. Okay. Okay, some complications. Primary viral pneumonia in adults. So remember, especially in the immunocompromised, they don't die because they're immunocompromised. They die because of the infection that occurs status post. Okay. In the elderly, which is bad, right? They'll die of the viral pneumonia that's caused by the drop in the immune system because they got the chickenpox. Infection in early pregnancy, congenital malformations in 2% of the cases. So varicella has a congenital deformity aspect of it. So if a pregnant woman gets it, they may spread it to their infant. There's a high risk of varicella complications. This is probably one of the ones where a lot of experts would recommend a cyclovir or valcyclovir for treatment of the patient. The therapy has not been completely established. The recommendation would be, hey, send them to an ID doc or have your OB take care of these patients so that they're aware of what you're giving them. Because remember, a cyclovir and valcyclovir are both category B medications, so it's somewhat safe for pregnancy. And here's a baby, congenital varicella. Look at his eyes, look at his upper left temple there. Okay. Here's another one. You can see scabs, right, after birth. So he was already developing the varicella virus in utero. Right. There's another one. He's actually forming the blisters now versus in utero. Okay, this gentleman has chickenpox. This gentleman may have suffered from SIRS, right? What we just talked about the other day. Right? He may have had a super strong over-inflammatory reaction to something. In this case, it was probably the chickenpox, in which case he ended up in the hospital and admitted. Right? But remember, for us as adults, if we do get it, our immune systems may overreact to some of this stuff. Okay, here's a whole bunch of different stages of the blister. And this is a combination of chronic cardiomyopathy myeloid leukemia and chickenpox or varicella. Okay. Here's some complications. Rye syndrome, right? I always think about that in kids, depending upon whether they're giving them aspirin or not. Herpes zoster is something that may occur to us. Most of us who have the varicella zoster sitting in our dorsal root ganglia, because that's where it lives, right? We never get rid of it. It always hangs out there. So as we grow older, if our immune system drops, sometimes it wants to come out, and it'll cause us some varicella zoster. Okay? Which means at the age of 50, we want to make sure that those older people get Shingrix, which will hopefully keep the varicella zoster down, and it doesn't pop up. All right. So our varicella leads us to the herpes zoster, right? aka shingles. Okay? So neurologically, since you guys were doing neuro, you guys remember your dorsal roots, your nerve roots? Yes, no? Right? There's little lines that come across your body, right? They come all the way to midline, all the way in different parts of your body. This one comes all the way across the anterior thigh, the inner thigh, right? So herpes zoster will pick one of those nerve roots, and that's where it goes. It is very, very distinctive. Okay? It looks like chickenpox, but in a specific dermatomal pattern. Okay? That is how you know it is herpes zoster. Okay? Symptoms usually begin with pain along the affected dermatome. That's another big issue with herpes zoster. Herpes zoster is painful. This thing is painful. Okay? Vesicles appear on the erythematous base. That's usually what those little blisters look like for varicella. Okay. It usually follows a specific dermatomal pattern. Pick one. Doesn't matter. That's the one it's going to go with. It could be on your chest, it could be on your leg, it could be on your face. Okay? It can pop up anywhere. All right? It's going to follow a specific pattern. Pain usually develops in that involved area, so wherever that dermatomal pattern is where that pain is technically going to be. Right? Usually you'll have the pain before the vesicles pop up. It's almost like a little prodrome. It'll be a tingle, it'll be pain, and then bang, up with your blisters. Usually, just like the cold sore, 2 to 3 days before, you'll start getting some of that, and then the blisters will pop up. Lesions may appear in irregular spots along nerve pathways, maybe one-sided, and these things are deep-seated. They're a lot deeper than the standard varicella, which is one of the reasons why it causes a little bit more pain. Whereas the varicella is just not extremely painful, it's more irritating than anything else. Okay? It says human herpes virus 3. Highlight some stuff. Dermatomes 1, severe pain 2, and for this one. Big issue with this is sometimes this thing can last for months. Doesn't usually go away real quick like some of the other ones within a week or 2. This thing can sometimes last for months. Here's your dermatomal patterns, and it can pick any of those, and it'll affect those areas. Okay. If it does get in your eye, where do you send them to? Where? Okay, great. That one I actually heard altogether. Ophthalmology, not optometry. Okay? If you do a consult and send it to optometry, they're going to kick it back. Like, this guy does not belong here. He needs to go to ophthalmology. Okay? If it does get in their eye, you need to send them to ophthalmology. Okay? Here it's showing you that it's a lot deeper seated. Okay? Because it's a lot deeper seated, it's going through the vessels. It's also affecting the nerves, which is why it's causing you a lot more pain. Okay? Immunosuppressed folks, usually atypical presentations, right? Their immune system's a lot lower. So the way they present may be a little bit different. And sometimes it'll be a lot stronger because there's nothing keeping it in check. If you want to do PCR, you can. If you want to do ELISA, you can. If you want to do fluorescent antibodies, you can. This is diagnosed clinically. You look at it, get a good HPI, that's what it is. Okay. But if you do want to do something, you can kind of take a swab of the vesicle and send it off to the lab. Okay. Usually a good HPI and taking a look at it is usually what determines the diagnosis. Remember the Zank smear or the Zank test? No? Okay. That one could be positive for this thing too. They don't really use that one anymore, but in underdeveloped countries they still do. But sometimes some of the national tests, they may put Zank smear on there as well for this. So if you look at these young ladies right here, okay, you can look right down the middle here is where that nerve loop comes from here all the way across and it just stops. Very telling. Same thing with this young lady over here. Right? Stops right midline. Okay, you have one dermatomal root that comes here, which will be probably B1 up of B5. Right? 1, 2, 3, and 1 is affected. Okay. Same thing with this gentleman, you have that demarcating line. All right, it already looks like his have already ruptured. Okay. This is the side of someone's chest, and it's following the dermatomal pattern right here. It could either be T4 or T5 that it's following, but you can see the pattern that follows is very distinct. Okay. Here's some more. This one probably just starting, coming across here. And you can see the vesicles in there, just like regular chickenpox. Here's another gentleman. You can see it across his back. Human herpes virus 3. This thing happens worldwide. Okay. Zoster is more common in the elderly folks. You see it too often in the young people. Okay. Common in the winter and the spring. Person-to-person contact, droplet or airborne spread of the fluid. That's the respiratory tract. And for some folks, it's just the reactivation of the dormant nerve cells that you have sitting in your peripheral cavity. Okay. Every 1 to 2 days, 5 before the rash. Onset of the rash, just spread it. 5 days after the first crop of the vesicles popping up, still spread it. Okay, so unlike smallpox, the scabs are not contagious. Susceptibility, universal, not previously infected. More severe cases in adults, it usually happens more commonly in adults and older folks. Here it says confers lifelong immunity, but don't forget that this thing is still sitting in your body, so it may reactivate. So not necessarily immunity per se. Okay, high-risk individuals. So there is a varicella zoster immunoglobulin. Okay. You guys remember what immunoglobulins do? What is it? Keeps you from getting worse. Yes. What does that mean? That's right. Passive immunity. Right? That's all that does. We don't usually give that to regular folks. Right? Healthy folks like you and I, if we have reactivation, we don't usually worry about that. Usually we worry about that with immunocompromised folks. Okay. Immunocompromised folks or little babies usually will worry with giving them some varicella immunoglobulin. Otherwise, for folks like us, okay, slug it up. Or we give them some cyclovir, and we give them some pain meds, right, because this stuff hurts a lot. And if they have not had the vaccine and they're over the age of 50, then they should get the vaccine. Okay, keyword should. Right. It's 2 doses, right? But it's up to the individual. We just need to make sure that you offer it. Okay, here's a baby, right? With herpes zoster, in utero, okay. Erytheum infecciosa. This is what we call 5th disease. Okay. The reason why we call this 5th disease because we have 4 other advancements that were found before this one. Right? Measles, scarlet fever, rubella, and skin scalded syndrome. Those are your first 4. And this one's the 5th one. Right? So, way to remember this. Okay. Your cheeks are going to be bright red. Okay. The rest of your face is going to look normal. Your cheeks are going to be bright red. You're going to see that kid over there is like, damn, you got some bright red cheeks. All right. Likelihood, erythema infecciosa. Okay. You don't even have to do any kind of that. All right. So this disease, the cerebral virus, most common ages 5 to 15 years of age. Okay. Usually happens within winter and spring. Parvovirus B19 is what causes the problem. Parvovirus B19 is what causes the problem. Incubation time period is usually 4 to 14 days for the onset of the symptoms. Okay. You'll have some headaches, runny nose, rash, and fever, facial erythema. Highlight that area. It says slapped cheeks. Say that for a reason. Okay? That is the most telling sign, without doing anything, is that this kid has a big giant red cheeks. Okay? It just causes mild constitutional symptoms. Okay? Nothing extremely big. Typical clinical diagnosis. I don't need to do labs. I don't need to do a whole bunch of stuff. You can do an anti-parvovirus B19 IgM. Figure out if that's what they got. Okay. Generally not done. Usually mostly occurs in the spring. Big things to be careful with this is that it may cause some myocarditis. So just keeping an eye on them is important. If you do end up with some severe complications, you can end up with hemolytic anemia, TTP, or post-infectious glomerulitis. But remember that post-infectious glomerulitis can occur with any viral disease that's exposed, right? And we just treat symptomatic. Okay? Motrin, Tylenol, your choice. Roseola infantile. Usually infection in infants and very young children caused by human herpes 6B. Okay, this one's also known as 6th disease. This is the next one they found. Okay, so we're very ingenious at the time. Okay, most common ages 1 through 5. So these guys are a lot younger. Okay, human herpes virus 6B. To be specific. Okay, history of fever for 3 to 5 days. Abrupt appearance of a rash. Okay, so the rash happens as your fever goes away. The rash appears. Very specific. As soon as your fever goes away, your rash pops up. The rash only lasts about 1 to 3 days, so it's not very long. Okay. The rash usually pops up on the trunk and back first, and then it spreads up and out. Okay? Now, these guys have high fevers. These guys have high fevers. Enough there to tell you that it may cause some seizures. Make sure you try to keep those fevers down. Okay. Usually rose, pink, macular, rash. Okay. Cervical or occipital lymphadenopathy. Cervical, most common lymphadenopathy. Okay. Cervical, most common lymphadenopathy. I want to clarify there, it says red papules on erosion of soft palate. Okay. What I want you to write, because I want you to clear it up, because I want to give you the most common stuff. This is okay, but the most common stuff is small pink to red spots. They kind of look like petechiae, okay, on the soft palate as well. But these guys are called Nagayama spots. Okay. So that's just to clarify that red papule. That you can just take that off and just write small pink to red spots or petechiae on the soft palate. Okay. We want to give you stuff that are most common. Okay, that's a lot more common than what these guys are saying there. Right? Just for clarification's sake. Now, as COVID spots were pathognomonic for measles, this is still not pathognomonic. It happens in about 30 to 40% of the cases. So you can keep that in mind when you're doing a physical exam on these patients. All right. I would probably cross off periorbital edema, eyelid edema. That is extremely rare. You may not even ever see that. So don't even consider that as part of what you're looking for. Okay. Remember, the fevers are extremely high, 104, 105. Okay. That can put you into seizures. We want to try to control them. Okay. Now here's the other thing with roseola infantile. Despite the kid having a high fever, right? We said this guy has high fever, 104, 105. Despite having high fevers, this kid is still roaming around and still playing. Okay? It's a little bit different than some of the other ones, right? Usually when kids have high fevers, usually they're down, they're listless, they're lethargic. But this kid, not like that. This kid, he's up and about and still messing around. Okay? So he's alert and active still compared to all the other kids if they have a fever. So that's a nice thing to note with roseola infantile. Okay. Treatment is clinically diagnosed. I don't need to do a whole bunch of stuff. Okay. Here you can do a serum anti for HV6B, but treatment is just symptomatic. All right. Biggest thing we got to make sure is that they're drinking plenty of fluids and trying to maintain that fever down. Okay. Here, if it's really, really bad, they say you can give the encyclovir, cidofovir, or forcemetal. Okay. But that'll be optional based on what the kid looks like. Right. And this is most often in the spring and the fall. Spring and the fall. Right. This is a mosquito-borne flavivirus. Okay. Somewhat structured similar to the virus that's caused by dengue, okay, and yellow fever and West Nile virus. Okay. Bigger things here to remember are that dengue is more hemorrhagic stuff, right? We talked about. Okay, this is not hemorrhagic. Okay. From what we know of right now. The biggest thing that we're going to really talk about with Zika is pregnancy. Okay, is pregnancy. For us, regular, healthy folks, not an issue, not a problem. It'll look like flu-like symptoms, it may cause some muscle aches, and then it goes away. No issues, no problems. Now, it's spread by the Aedes aegypti. Do we have Aedes aegypti in the U.S.?
Yes.
Yes, we do, right? And we have had some positive cases in Florida and Texas. Here it says sexually transmission has been reported. Is this considered an STI? No, this is not considered an STI. The reason why this is because they have found some of the virus inside sperm of men who have been positive for Zika. Okay? So we can spread it. Okay? And then vertical transmission for pregnant women and fetus is prominent. That is really the big thing that we're going to focus here, is that. Okay? Here it tells you Zika similar to dengue. Okay? Horrible consequences for the offspring of pregnant women. That is our biggest concern, is pregnant women. Florida, Texas, Puerto Rico, St. Croix have locally acquired cases. All Walter Reed is currently working on a vaccination. And we currently don't have one yet. And then if you look at that very bottom one, that CDC study, I'm not going to read all that to you, but birth defects were reported in a higher proportion of fetus or infants whose mothers were infected during the first trimester. And the first trimester is the worst trimester for anyone to get infected with Zika. One of the educational aspects that we tell folks is, hey, don't go down there while you're pregnant, don't go down there. When I say down there, it would be to these endemic areas, generally Central South America and the Caribbean, okay? Because we want to make sure that they don't get this. Incubation period is usually about 10 days. Acute onset of fever, micropapular rash, usually itchy. Okay? Non-purulent conjunctivitis with arthralgias, usually a week, and then you're all better. Most of us are generally asymptomatic. We don't even realize that we have it. Okay? Asymptomatic and symptomatic pregnant women traveling to endemic areas should be tested for IgM 2 to 12 weeks, and even longer after traveling to the endemic, to the area with Zika activity, or if they have had sex with a man with a confirmed Zika positive infection. Okay? Extremely important, because if they're exposed to Zika, we need to follow them. All right? We need to follow them. If you do want to check some stuff, you can do your IgM via ELISA. The better one that we have now, just do it RT-PCR. This is RNA, so you can do it RT-PCR, and that'll get you a much better result. All right. Zika can be passed through sex from person with Zika to their partners. This is one of those big. Why we really need to check if they've had intercourse with someone who has had a positive confirmation of Zika. Okay. Usually for men, it's on the average of 3 months status post, getting better, but they can still spread it. And for women, usually it's an average of 2 months status post, but they can still spread it. Okay. I probably remember this slide. 2 neurologic complications of great concern with vertical transmission. Okay, microcephaly and Guillain-Barré syndrome. Babies aren't going to get over that microcephaly. Okay. Extremely important. There are some other complications there. Most of them include the eyes. And they still have ongoing studies. We have no antivirals for this stuff. Treatment is basically supported. Breast fluids, prevent dehydration. Acetaminophen if needed. Okay. They say no NSAIDs. Again, they were initially thinking that because it's so likened to ganglion structure that it may have a hemorrhagic aspect to it. As thus far, there is no hemorrhagic aspect to it. You want to be safe, you just use acetaminophen. Alright. Mosquito avoidance, if at all possible, right? Prevention. That's usually what we try to do if we can. And if we don't have a vaccine, try to prevent getting bit by one of those mosquitoes, which we don't know which ones they are. Okay. Anybody have any questions? Alright. I'll be right up here for a